Good evening, everyone. I want to thank you very much for attending tonight's discussion about healthcare with Elizabeth Edwards, moderated by Ezra Klein. My name is Ariel, and I'm an events associate at Campus Progress. Campus Progress is the youth outreach arm of the Center for American Progress, and we work with students throughout the country to help them make their voices heard on issues that matter through our programs in journalism, activism, and events, just like this one. I'd like to take this time to thank George Washington University for allowing us to use this room and to acknowledge tonight's co-sponsors: the American Medical Student Association, the DC Society for Young Health Policy Professionals, the GW Student Health Association, and the GW Health Policy Student Association. We teamed up tonight to host this event because we recognize the importance of getting young people involved in the healthcare debate. A discussion about healthcare as it relates to young people, directed at young people, is rare. So we really want to take this opportunity to be with all of you tonight. Healthcare is an issue that I'm particularly passionate about, and it's been a goal of mine since starting at Campus Progress to get more young people involved in this issue. When I saw a few weeks ago in the news that Ms. Edwards was frustrated that healthcare was no longer on the radar, we saw a great opportunity to bring healthcare back into the spotlight, and especially to all of you. We're thrilled to have Ms. Edwards here with us tonight, Senior Fellow at the Center for American Progress, a dedicated advocate for healthcare reform, accomplished lawyer, author, and blogger, here tonight to inspire and enlighten us about healthcare and healthcare reform. Moderating tonight's discussion is Ezra Klein, Associate Editor at the American Prospect. Please join me in welcoming Elizabeth Edwards and Ezra Klein to tonight's event.
All right, are we on here? Looks like we are. So we were just backstage, and Elizabeth turned to me and she said, "You know, the last time I did one of these, I was at the New Yorker Festival, and the moderator was Atul Gawande, and he was so good. He said so many interesting things about surgery and about medical practice, so I almost walked out the back door."
Actually, I was going to say I thought Ariel did a very nice job, but you were undersold. You're not just you don't just write for the American Prospect, but you're also one of the best healthcare journalists and bloggers out there. So I'm actually feeling a little intimidated in your presence.
All right, we'll take that, Atul Gawande. So we're going to chat for a while about healthcare tonight, and I think we're going to start with where some of Elizabeth's newfound prominence in the healthcare debate came, which is when, in the sort of dog days of the summer, right after the primary closed out, when Barack Obama sort of forgot the words healthcare, and John McCain had this sort of odd plan coming, Elizabeth made news for saying correctly that under John McCain's plan, neither her nor him could receive health insurance, would be covered by any health insurer who wanted to make a profit. So why don't we start there and have you reprise some of that and explain what you meant, because I think at this moment it's fairly relevant.
No, it is. One of the things when you're young, try to follow Ariel's advice. When you're young, you think you're never going to have any conditions that need any attention. You don't go to the doctor that often. The problem, of course, is that if you do, or when you do, develop some sort of a condition, it therefore then becomes a pre-existing condition for your health insurance. And you go out to try to get health insurance, and you find that you can get health insurance for all of your health problems except that one thing that's really your big problem. And that's the problem for me, and would be for John McCain if he had ever been on anything other than a government program in his entire life, which he hasn't. I could say that because as a Navy daughter, I also benefited from Navy medical services as well, as he did as the son of a Navy admiral. But so we need a healthcare system that's affordable for people and accessible, but also in the end produces a product that you actually need. So it means it has to cover the conditions that you have, and if you eliminate some conditions, we don't have, we may have everybody covered, but not for the things that bother them. They're big medical crises. So you need to make certain that your policies are not only affordable from the individual standpoint, affordable from the government standpoint, but also that the product they're producing in the end is a product that actually people need. And I think that he fails really almost on all three of these categories.
I want to continue on that, but I realized I just forgot to say something in the intro. My understanding is everybody's got cards out there on which you can write questions for later. At about 7:30, you can pass those to the right, and they'll pick them up, and we'll read some of them out here. So you should look for them and have them ready if things come up. But to pull back onto McCain, one of the things that I think is sort of interesting about his healthcare plan and the general conservative belief on healthcare is that the decision maker here is supposedly the consumer, right? As if it's like walking into Best Buy and picking up a flat screen television. Right. And you've had some recent experience with the healthcare system and quite a bit in study as well. And I'm always a little bit struck by this form of reasoning because I've never wanted a medical treatment in my life. I've never enjoyed antibiotics, never thought, I got nothing to do on Sunday, let's do a diagnostic. It's never happened. And it always struck me that the doctor, to some degree, is a decision maker. And that the question of, you can make it harder for people to afford care, but it's hard to make it different for them to decide care.
Right. And it's problematic to decide care. And I think that you do want to be involved when there are choices to be made. You want to be involved in those choices as a patient. But you also need to trust the doctor to help make decisions, after consulting you about what kind of treatments you want and what options you want, what your goal is. And Senator McCain, honestly, was one of the original sponsors of the Patient's Bill of Rights in 2001 with actually my husband and Ted Kennedy, which was going to do that, take insurance companies out of the decision-making process and leave the decisions to doctors and patients to make those, to decide what was the appropriate kind of treatment. Senator McCain not only does he seem not to talk about that anymore, he goes a step further and basically starts knocking the doctor out of the process. You're supposed to, as a healthcare consumer who now has a tax credit, you can designate where it goes to pay for your health insurance. You're supposed to go out and decide what the best health insurance is. And because it's your dollars you're using, you're supposed to be better at negotiating the best possible product. It's exactly the same right you have probably with your credit cards. Anybody negotiated successfully with a bank? That's exactly the problem. The problem is these are contracts of adhesion. You're not going to negotiate them. And the people who do have right now can do it, who have the money to do it, are people who have put money aside in these health savings accounts. And they can go out and buy their health insurance from where they want, from whatever vendor, and make those exact decisions. And what we find is that they're not negotiating. They're not educating themselves and trying to find the best possible price. They're trying to find the best possible product. It's not like this. I understand. I really, and I don't even necessarily want to quibble with his conception that the free market can operate effectively in some venues. Healthcare is not one of them. This is not a refrigerator. It is not a television set, and it is something that is not only a necessity, but it's something about which we can't look at the picture and say, yeah, I like that picture, and that'll fit in my house, so I'm going to get that TV set. We simply individually unequipped. I'm unequipped, and I feel like I've spent a lot of my time thinking about healthcare, and I'm unequipped. All I can do now is punch my conditions into the internet services that tell me what my healthcare premiums would be, and let me tell you that my healthcare premiums for my family would not be $5,000 a year as McCain's tax credit is. But that, although frankly, to be perfectly honest, the tax credit is probably going to be enough for most people in this room who are young and healthy. And if you plan to stay young and healthy, they'll be perfect for you. If you think that might change, you might want a larger tax credit than that.
Let's take a moment on that, because the health savings account side of this is interesting. And you hear from folks, right, that it is cheaper. We all don't need to go to the doctor all that often. And in that way, it's sort of an interesting vision of health insurance. It's health coverage for people who don't need health care.
Right.
Which seems like a sort of a puzzling way to approach it, but in a way, I guess it makes sense, right? The vision they have, which puts cost control before access, puts lowering sort of aggregate costs before getting people into the system, I guess the idea is that if you can get people to buy the cheapest insurance possible, then we will all spend less. And that's a correct idea.
It is, but the problem is the product you get. That's why I said the product you get is a really important component of this. The state of Florida, I actually don't know whether they've actually gone through with this policy, but the governor signed the bill, I think, that allowed them to introduce a new, really cheap policy. It's going to cost $1,800 a year, $150 a month. That's a pretty cheap policy. That's for an individual. And the problem is that in order to make it so cheap, and get the insurance companies to sell it, what they did was that they said, okay, you don't have to follow this rule and you don't have to follow that rule. The state of Florida, like every state, has rules that they require an insurance company to follow. If you're going to offer a comprehensive policy, it has to have coverage for maternity care. Although, frankly, I think only 21 states require coverage for maternity care as part of a comprehensive policy. But if Florida did, they wouldn't have to. And do you know how many of those things they avoided in this new cheap policy? 150. 150 requirements that the state had already decided were necessary for a decent policy were not going to be a part of the new cheap policy. Well, so you have a piece of paper, but none of us want the piece of paper. We want the health care that's associated with those 150 requirements. And that's the problem, is that he's giving us the language, but he's not giving us the product that we need. And it's really problematic when you go further down the line and look at his plans, because one of the things he wants to do is allow that Florida policy basically to be sold everywhere. Policies are why there's Blue Cross of North Carolina and Blue Cross of Virginia and Patriot Blue Cross or whatever they have in Massachusetts. In different states they have different healthcare companies because each one has to comply with that particular state's regulations. Some states are a lot more consumer oriented than others, and they have those different regulations we were talking about. So where do you think, one of the things that Senator McCain wants to do is say that you can sell across state lines. Well, this is one of those things that sounds really appealing. Then there's not so much overhead and you can get the best possible deal and you're not limited to, the place on 90, limited to Carr Lake on 95. You can buy it from across the river, across the lake in Virginia if you get a better deal there. And then some places like Pennsylvania and New Jersey, where the prices are really different when you cross the river, it seems like that would be a really good idea. The problem is that it's going to be like those credit cards I talked about earlier. It's going to be, you're going to get the worst possible state as your option. Robert Gordon, who's also associated with the Center for American Progress, wrote a great piece in Salon, it's probably been a year ago, about this precise issue, and he described what happened with credit card companies. Supreme Court the law had previously been that the law that applied to your credit card agreement was the law where the borrower, that is you as the credit card user, lived, not the law of the lender, the credit card company. The Supreme Court said no, it was the law of the lender could apply. So the president of Citibank calls the governor of South Dakota and says, I'll give you 400 jobs. 400. If you want to know why your credit card comes from South Dakota, 400 jobs. 400 jobs if you will pass laws really favorable to the credit card companies. It took them 24 hours. If you don't think exactly the same thing, it's not like they don't know this, exactly the same thing is going to happen with respect to health care if we were ever to enact this thing where we didn't have the protections, unless, of course, there were federal protections, which is what I'd most like to see.
Right. It's funny because I think sometimes folks hear that analogy and think, oh, those liberals, they're so mean to John McCain. But in the Journal of Actuaries, about a month ago, there was an article bylined by Senator John McCain, and it said, if we can eliminate state regulation, we can bring more efficiencies to the healthcare marketplace and make it more like banking, which came out like right at the wrong time. So, I write for a magazine. They're long lead times. Like these things are rough, but it doesn't really get away from the argument there.
Right. The magazine's like contingencies, and it's
contingencies.
It's the September-October issue, and he gave this interview in June or something, it was his bad luck that it came out in end of September.
No, somewhere in the John McCain campaign, there's like a guy who wrote this article for him, who, if John McCain does get elected, there will be an exception made to the torture policy, the no torture policy. But one other thing here on McCain before we move on from him, you mentioned that folks with pre-existing conditions are knocked out of contention under his plan. But there's one other group or player in the current market, which is employers. The part of the theory of John McCain's plan, is you tax healthcare benefits, which on the employer side, which you've never done before. And that a lot of liberal healthcare wonks, I would argue, others would argue that the fact that we have a healthcare system built off of a World War II era tax quirk meant to protect against companies' war profiteering, but they could put that into compensation, if not wages, is a little bit odd and probably should be eliminated. But what he does is he takes that away. So there's about a $3.6 trillion tax increase on employer-based health care, which means, according to most estimates, that about 20 to 28 million people will be kicked off of employer health care. And then he gives folks a tax credit for the individual market, which is sort of a different market. And you see commentary on this, and people sort of treat it as a one-to-one. That, yeah, well, they're off of the employer market, but they're on the individual market. So I guess it's a question in two parts. One, is that a fair trade? But two, how should liberals react to this question of leaving the employer-based market, which in many of the plans that we support would be a pretty key ingredient, particularly over the long term for cost control?
Right. Let's say there's lots of parts to this. One of the first things I want to say is Senator McCain does have a plan for people like Senator McCain and me with respect to our pre-existing conditions, which he puts us into a pool of people who are unable to be insured. It is extraordinarily expensive. And if the federal government is helping subsidize this, we are grossly underestimating the already enormous cost of his plan. That I just wanted to sort of cross that T before I moved on to this. As you're looking for jobs, one of the things you want to look for is jobs with health benefits. I was just listening on my way up here from North Carolina to the fellow Brendan Gill's son, Michael Gill, who's written this book about working part-time at Starbucks, and Howard Schultz's father had no insurance when he broke his leg, and he vowed that if he ever was in a position to have a company, he would make certain everyone had health care. So even if you're a part-time employee at Starbucks, after 90 days you have health care. One of the things you look for when you're looking for a job is someplace that has health care benefits. Two things are going to happen if John McCain's health care policy were to become law. One of them is that your health care benefits, if your employer does provide them, will now not be a benefit that you get sort of as a freebie, but you'll get taxed on it just as if it was income, but you don't get, you won't be deciding how it's used. You'll get taxed for the full value of it. The employer contribution to a normal family plan averages about $9,000. The plan itself costs about $12,000 on average for a family. You pay $3,000. On average, the employer pays $9,000. Now you will be paying taxes on that $9,000. That will work out as because you get a tax credit for $5,000. It actually works out to your benefit at first. But because healthcare prices have the cost of health insurance has gone up like this, and the value of the tax credit will go up like this, really. The turtle and the tortoise and the hare. You'll lose that. So by 2013, everybody will be a tax loser on that plan. Healthcare premiums have gone up 2001 to 2007, like 91%. And he's talking about cost of living increases down here. For the tax credit. So everybody will be a tax loser on it. The other thing that's going to happen is that some employers will decide that they're not going to pay, they're not going to just do the things. They're getting a tax credit, maybe give you a little bit more money and let you go out on the individual market. And isn't that the same? Well, it's not the same. And part of it is really understandable. When you're an insurance company, and you're going to insure a big group of people. Students is a great example. My sister lost her health insurance and is now a student and is covered by student health insurance, which is less expensive because who are students? They're those young, healthy people. So what they do is they look at the whole group of people. And these are people who are working people, and so they're coming to work on a regular basis, and they can assume certain things about them, about the group as a whole, and they decide what the cost will be for individuals, for the group. When it's individual, and it's also less expensive because they underwrite for a whole group of, depending on the size of if it's 30,000 students, or if it's 10,000 employees, or if it's 200 employees, they underwrite, and that process has a limited amount of administrative costs. You go in individually, and they underwrite the risk associated with you. I frankly, I'm like somebody who's currently on fire, and my avocation is jumping out of planes with no parachute. I'm a really, really bad risk. So when but they make an individual decision. As they make those individual decisions, they can decide to charge me a whole lot because I'm such a big risk. Whereas if I were part of a group, they would spread that risk among everybody. And the other thing they do, of course, is they've got a lot of cost associated with figuring out how much it is. So it's not actually a one-for-one trade. My premiums are going to be a lot higher. It might be harder for me to get. And if I were part of a group, I could get it. This fellow, Michael Gill, has a brain tumor. He was employed by Starbucks while he had a brain tumor. So he's covered by their insurance as part of a group. Individually, he is virtually uninsurable. And so that you have all of those things that are playing at one time with the health insurance.
I just add to that because I was frantically reading on my way here in an attempt to match Atul Gawande that the Health Affairs estimates that the same plan on the employer and individual market is $2,000 more on the individual market. So if you've got $2,000 extra dollars around, that's okay. If you don't, it's not. But I say
one more thing about this, and that is that one of the things that Governor Palin in her debate was talking about the health care plan. And was not particularly well informed about it, and said that it was budget neutral. So they're scrambling to make it budget neutral, and it wasn't going to cost individuals. The problem was that not only are those wages, those health care benefits, not only were they taxable to you as income, they were also subject to Social Security taxes, other payroll taxes, and therefore it was going to even take a bigger, chunk out of your paycheck because of it. So in response to Governor Palin's comment, they said, okay, it doesn't actually cover. They're not going to pay payroll tax. You don't have to pay payroll taxes on it. The problem, of course, is that creates a situation where it's costing $1.3 trillion over 10 years more than what he had previously estimated it was going to cost for the program.
Yeah, so then they said they're going to cut Medicare and Medicaid, which is going to play great in Florida.
That's how they're going to pay for it, by cutting Medicare and Medicaid. And it's not the only thing they're cutting. They're also cutting $30 billion a year out of health care, farming, and ethanol subsidies. Actually, so the farming and ethanol subsidies are like this, so they're cutting even more out of health care. So, good luck to the people who are on Medicaid and Medicare, and I realize that in terms of the audience, that's not my target audience tonight.
But let me push on one of the points here, which is just at the end of the employer market. Put almost aside McCain's plan, that has to happen at some point, right?
Well, it probably needs to happen at some point. The health insurance arose targeting particular employee groups. The first health insurance was actually sold by a hospital in Texas. They had more beds than they had patients. They were trying to get patients to come into the hospital. It didn't used to be the thing where people would go to hospitals. So they offered health insurance to teachers, and they paid 25 cents or 50 cents a week to be insured by this hospital, and you could go to this particular hospital, and other hospitals started doing the same thing, and then they started getting these collections where you could go to any hospital, and they started by targeting employment groups. So the first way we started thinking about insureds is in terms of their employment, and it was sort of an easy way to target people in a society that didn't have computers and didn't have, all of the things we have now that allow us to identify people in other ways. But obviously, that we often hear that GM puts more money into healthcare than they put into steel and a car, and that creates a competitive disadvantage for them. And so we need to find some way to do it. At the present time, with healthcare costs spiraling at the rate they are, until we can get that under control, it seems to me it's not realistic for us to go cold turkey on the employer benefits.
But something that, one of the things that always struck me, and I guess this is a good way to transition over to the Democratic plans, is that there seemed to be a sort of an implicit recognition of that. And so the Democratic plans, your husband's included, but Obama's as well, Clinton's as well, what they sort of do is they make a bargain. They leave everybody alone, which Clinton in 1994 did not do. They were going to change everybody's health care. That scared the hell out of everyone. It was a little bit of a weird political move. You're worried you're going to lose your health care benefits. I'll tell you what I'll do. I'll take your health care benefits, create something new. You're going to love it. The government will be here to give it to you in the morning. But what it seems to me the current sort of bargain is that we don't touch it now, but we pay enough money to create this other thing over here, modeled off of the way we give healthcare to federal employees, where we have sort of a regulated market of insurers who can't discriminate, who have to fulfill a minimum coverage standard, et cetera. And we sort of hope that the efficiencies there and maybe some subsidies that quietly go in on the back end and so forth will make it so this naturally becomes the healthcare market, so that GM, and it's my pet peeve, steel is not expensive anymore, people. That they don't pay that much for steel in cars, but they pay more for electronics. But that GM and Walmart and all these folks decide, rather than putting 10% of payroll towards healthcare that we buy and administer and worry about, so we make cars and widgets and make medical coverage decisions, that we will pay 6.5% to the government and people can then go in and buy it. So it always sort of struck me that was an interesting compromise, that you leave it alone for now, but you try to create a sort of soft transition where people can choose to move over of their own volition rather than being told by the government, listen, we know we got a better idea here in the back, just wait for us to bring it out.
I mean, I often describe it. I know that there are a lot of people who sincerely believe, and having grown up, frankly, in the military, which is a single-payer system, I have no fear of a single-payer system. But I can understand if you were in the middle of chemotherapy or something like that, and somebody said, "Okay, everything's switching tomorrow." You say, "Wait, you know, I'm not ready to do that." So, to make the transition easier for people, it allows any sort of a hybrid that allows people to create a level of comfort before they move to Senator Obama has as one of his insurers, and my husband did too, as one of the insurers who are available, not only the private insurers, the Blue Crosses and the United Healthcares and whatever, there'll also be a public insurer. And the public insurer would be kind of like the Clinton insurer in a sense, that Medicare Plus or some other, whatever kind of language you want to use it, and people can opt to choose that for their health care. Kind of think that at first people aren't going to jump to it. I don't think people are going to jump to government health care. But considering that the overhead is so much lower than it is, 3 or 4% as opposed to 30 to 40% by the private insurers, the same dollars are going to probably get you more. So maybe your next door neighbor decides to go and you realize that you had to pay for something that they had covered, and I think you will gradually, over a period of time, see people gravitate towards that more comprehensive policy at the same price. Now, that doesn't get the employer out of the process. Getting the employer out of the process is probably got to be a result of the price coming down generally. If it's $12,000 a year for a policy that really takes care of your family, it's really hard to see how people are going to be in a position, unless wages go up, tremendously, which means that the price of our goods is still not competitive, how it is we're going to be able to extricate them in the short term. So we have to, it seems to me, find some weaning process that allows cheaper good alternatives to be introduced into the market, have people gravitate towards those, and then have that be a process of evolution. I'm concerned with anything that goes cold turkey, either on you have to move out of your private insurer, get that Blue Cross Blue Shield card out of your pocket and tear it up, or anything that is really drastic with respect to the employer's participation. But I'm really, I know most people are pessimistic when, we can't do anything about healthcare costs. The costs of, we're now doing more testing, and the prescription drugs are so expensive, and I mean, I have MRIs all the time, and look at that machine. What in the world does that cost? But I'm actually pretty optimistic about the possibility of bringing healthcare costs down. We've just put our priorities in all the wrong places in so many ways, and I honestly think the financial markets have had exactly the same problem. We are just so short-sighted. They're only interested in what the quarterly report says or what the annual report says in terms of profits and whatever. Insurance companies should have been notifying me every single month. I mean, I had a bad mammogram in the 1980s, and then for a long period of time I didn't have any mammograms. So they thought, that's all right with us, saving us a couple $100 when she doesn't get that mammogram. Only they're paying that every couple of weeks now, because I didn't get the mammogram. We're really stupid about the way we spend our healthcare dollars. We're unwilling to spend the dollars today that will save us money. We need to have, and apparently the insurance companies aren't going to do it on their own. We need to have government intervention that requires the kind of screenings and wellness treatments that people talk about the candidates all talk about, but they don't actually budget for in terms of what happens. The CAP has got an idea, which is, I think, a really fantastic idea, the Wellness Trust, where the government actually takes control of that part of it. And the government pays for that part, that will help us eventually bring the cost of things down, diagnostic testing, preventive care, and wants to, for example, locate those kinds of interventions where you live. I've always talked about the fact that I want us to have community health centers all over the place. Everybody can go to them. Everybody has, and move them out of the stigmatized area. My community health centers are located in the poor neighborhoods or back behind the public hospital, in some area near projects or something. Move them out to where people live and have people start using them on a really regular basis for those kinds of basic tests. I think they should be in elementary schools. Why? Because they build elementary schools where population centers live. And, if there are people there, they build an elementary school, and we could put them in those kinds of places. We could get those kinds of tests. We could intervene. I'll give you an example. Diabetes. Diabetes is 47 states, I think, require diabetes supplies to be provided for, but 3 states do not require insurance companies to pay for diabetes supplies. So you don't pay for diabetes supplies under the insurance, and they're not cheap. It costs you, several $100s a month to pay for them. I had gestational diabetes. I've forgotten what it costs now, but several $100s a month for your testing supplies and everything. You don't do it. What happens is people's condition gets worse. And what are the results? Kidney failure, blindness, stroke. These are pretty expensive kinds of conditions to have. And what did they save themselves? They saved themselves the cost of supplies. Not only do people's quality of people's lives worse, which is clearly the case, but also they've made a really stupid economic decision. And why did they make it? I think they made it because we are so fixated on quarterly reports. We are so fixated on the annual profit, on the dividend that we're offering at this particular time. And so that's where all their attention is. Corporations have a fiduciary obligation to their shareholders and no fiduciary obligation to their insureds.
I think you make an interesting point here, because people often set up a tension between you can lower cost, but if you lower cost, you're going to have less care.
Right.
And you're sort of making an argument that actually you can lower costs by making care better. But it's funny because there really is a lot of sort of fear around this, like Canada, right? My understanding of Canada is it's a waiting line. It begins in Ottawa, it ends somewhere in a Walmart outside Buffalo, and nobody can ever sit down. And that sounds pretty bad, but you're making the argument that you don't need to ration based on denial of care, but that before you actually got to more drastic steps, that there would be ways to increase the efficiencies by making people literally healthier.
I really believe
being sick is expensive.
It is expensive. Now, do I think that in year 1 you save a lot of money? No, in year 1 you probably cost you a little money. But by year 5 you've saved pretty much money. By year 10 you've saved a whole lot of money. By year 20 you're really operating an incredibly effective system because you're intervening at the earliest possible date and giving people the treatments that they need before the conditions have gotten worse. And of course, if you're also investing in research at the same time at a level that we're currently not doing, then you're also finding answers to some of these conditions. The notion that we, for example, that we can't save Medicare except by really cutting the benefits or by doing something else is, I think, foolish. 70% of the costs in Medicare are associated with chronic condition, with like 5 chronic conditions. And why did they get to be so expensive? It's because they didn't get treatment. They weren't intervened at the earliest possible time. It was that diabetes or the cancer that didn't get found because people weren't getting tested. If we're intervening at an earlier time, we can actually do things that also don't maybe matter to you, but saving Medicare in the long term. The analysis of how much money would save Medicare if we just started doing those things is incredible. And if it's saving Medicare when people turn 65 or 67 or what, it will also save insurance companies when we're 55.
We were talking today about how, it's probably important to talk about Medicare, but how can we bring this in with the young? And when you were saying that, I remembered a Robert Samuelson column from a week ago in the Washington Post, and it said at the top in one of the more sort of annoying journalistic devices, to young voters. And it was about how we all should be furious at ARP because they're not letting Medicare get cut, and so they're mortgaging our future. We're going to have to pay for it. And the end of the column was an exhortation to go picket outside the ARP office, which would be weird, I think. But I want to make one point on that, which is that if you look at the graphs of what's about to happen to our economy, and they're right, healthcare is going to break its back. It isn't really Medicare. If you let Medicare go straight, you let Medicaid go straight, you don't change it at all, our incomes go up over the next 50 years. Not as quickly as we want them to, but they go up. If you don't fix healthcare, they go down. It happens to be the case that the government provides a lot of graphs where the red line goes down if things aren't getting better, and so people, oh, look, the red line's going down, we've got to fix that. And nobody does that for the private market. But Medicare cost growth is slower than private cost growth. Private cost growth is going to eat us all soon enough, and if we don't do something about that, if we don't fix the drivers of spending growth in Medicare, raising the benefit age, you'll have to do that again 3 years later, again 4 years later. You keep having 8.5% cost growth, and you're in trouble. But
there are also things that insurance companies don't cover right now because they need to make money, so they cut things out. Actually, do have to do with you. HPV vaccine is only required in 16 states to be covered on a comprehensive insurance policy, which means that if you're a woman, you want to get this vaccine, maybe it's covered and maybe it's not. Because the insurance companies are making a cost determination that doesn't serve you. I think the chlamydia was 6%. Was that right? 6% of states, 6 states require that to be covered. Infertility treatment is 23 for in vitro, I think, and 6 or 8 for other kinds of fertility treatments. And as I said, maternity 21. These are all issues that really only affect young people. But the insurance companies are making these decisions because they have a profit margin to protect. And they have to protect it because 70% of their dollars are also going to those chronic diseases. So you want to free up those dollars. So even if the conditions aren't ones that you have, you want to free those dollars up so that they can use them on the kinds of health care that you do need and will want in the years to come.
I think I should quickly say that Ariel is going around collecting the cards. If you have a question, now's your big moment. You talked about everything you spoke about, though, where you can save money by making people healthier, requires folks to have the access to actually see a doctor. They require them to have some sort of level of easy interaction with the medical system. So that's a very, I think, extremely effective segue to a different question, which is about mandates in the Democratic plans. And you were sort of you and your husband's campaign were big in first instituting the idea that Democratic healthcare plans do need a mechanism for universality, that you can't really just hope that you make it a little bit cheaper, which may or may not work anyway, and then everybody signs up. That there's something fundamentally, both morally and on a substantive policy level, efficiently important about having some sort of mandate, be it on the government side, be it on the individual side, to get health care. And Barack Obama, who ended up winning the primary, does not have that in his plan. You think that would be a serious deficiency?
I do. I mean, he has a mandate for children, which is really good, and I'm in favor of that. But you need a mandate. Everybody has to be covered. I mean, first of all, that's what universal means. Everybody is covered. And you can't just say, I'm going to make it really cheap and everyone's going to buy it. You've got a chicken and egg problem there, because it gets cheaper when everybody buys it. But it does get cheaper when everybody buys it. But that doesn't happen until everybody buys it. You think about, and I'm critical of my own husband's plan, and that was that he had regional pools. We need one national pool of people. If you think about an insurance company, what they do is they insure a bunch of people. If you take it out of healthcare and it's fire insurance, they insure everybody's houses. Everybody who wants to get health insurance, they insure everybody's houses on the assumption that everybody's houses won't burn. And that they'll make money on some premiums, and they'll have to pay on the ones that do burn. So we need to make certain that group of people we're talking about is the largest possible group of houses, because that's what creates for them the incentive to keep the prices low. They spread the risk over the largest possible group. Not only that, but the fact that there is different from the fire insurance in this way, the fact that there are uninsured means that those people are still going to get sick. They're still going to go to the hospital. Right now, and these are actually old numbers. I think the new numbers, if I've been promised that they'd come out some time ago, but they haven't, as far as I know. But some time ago, it was costing you $900 a year extra on your health insurance because there were uninsured out there. You have cost shifting that happens. Hospitals will have to charge more for something because they need to make certain that they cover the costs associated with uninsured. If you get a treatment in a hospital, they keep basically two sets of books. They charge the insurance company $1,000 for your treatment. You don't have insurance, they charge you $5,000 for your treatment. The same exact treatment. Why did they do that? They did it because they know they're not going to get $5,000 from you. And they know a lot of those people are going to end up going to charities, and the charities will pay a portion of it, and then they'll hope to get $1,000 or $800 or something out of it. What that causes is enormous bureaucratic. We're talking about Canada. I ran into the woman who had worked in a hospital in Vancouver, and she had moved to Boston. I met her in one of the New Hampshire primaries, and she said she worked in the accounting office in the hospital and went to a hospital in Boston to get a job. Same number of beds in the hospital, in each of the hospitals. She got a job. She had worked in an accounting office with 6 people. She now worked in an accounting office with 600 people. Your health insurance dollars are being used to pay those 600 people. It is not an efficient use of our money, because they have these different ways of trying to collect, trying to cover, trying to make certain. So everybody being insured eliminates so many of this game playing. This is a shell game that's going on, and it eliminates a lot of that nonsense and allows us to really focus on how it is we drive the costs down.
So let's talk a bit then about after the election, because I know we're wrapping up here. A couple weeks ago, folks really felt that this was, maybe a couple months ago, the moment for healthcare reform. For the first time since 1994, you could feel the momentum building. I think 2 things happened. I'll ask you about both, but let me start here. You spent a couple of years within the Beltway at times, and you met a lot of the folks who will be responsible for casting the up or down vote that would theoretically bring any legislation into implementation. Do you think senators, politicians, Democrats or Republicans are afraid of health care after 1994?
There probably is some fear associated with it, but I'll be honest, I think that as our economic situation worsens, there's probably going to be even a greater demand from their constituencies that we address this issue that is not only important to their pocketbooks, but important to the quality of their lives. I think it's going to, it may be toxic both ways. This is a vote that, and it's my hope that they will feel the moral obligation when confronted with that conflict. I also think it's probably there's more weight on the side of voting for health care. And I would hope that the president would be really proactive in going out and campaigning in areas where for health care, in areas where we had recalcitrant members of Congress.
And then you had something happen, which was our economy collapsed in on itself. And that created some sort of odd ripple effects. And one of them was that in each and every debate, including the vice presidential debate, you had the moderator sort of sagely lean forward and say, with the $700 billion bailout, which won't cost that much, and with all the economic turmoil, won't you have to rein back your plans here? Can we really afford to do things like healthcare? And somewhere you could hear Keynes like very softly spinning in his grave.
Yeah.
But beyond that, do you think this is correct, that because we did a bailout bill, because we've sort of some real financial turmoil, that things like healthcare, they got to take a back seat for a while, they got to wait for a time of calm?
Well, if you'd listened to the answers, you would have assumed nothing was taking a back seat. Everybody was pretty much guilty of that. Well, the one thing I'm not going to cut is, and I'm not going to cut, and there were even things on that list I didn't know they were actually doing until then. But infrastructure made it, into the list several times. But there is going to be pressure to define everything. I mean, healthcare as an answer to our financial problems. But honestly, I think it is. I think it's part of the answer to our financial problems is dealing with healthcare. There's been a study that came as in Health Matrix magazine, came out of Harvard, that said half of the bankruptcies half of the foreclosures. You think they're all subprime mortgages on your street that are houses in foreclosures? Half of them are associated with health care. They're health care reasons for half of them. So if we were to solve, for example, the subprime mortgage problem, which is not the only problem going on, but if we were to solve that problem, real estate values would not pop back up again because you still have half the houses in foreclosure on your street because half of them have nothing to do with the subprime mortgage crisis. One of the analysis in this study says these people bought houses that were less than the average cost. They earned salaries more than the average cost, but cost of healthcare was so crippling, or the burdens of healthcare so interrupted their work so much that they were unable to meet their mortgage obligations. So solving health care is an important part of putting individual families back on the financial footing that they're going to need to be from their perspective in solving the problem, and to the extent to which the value of the underlying assets, the real estate, is important in this asset-debt ratio problem that so many lenders are having. It's also going to be important in solving that problem as well.
So we are now moving into the long-awaited Q&A session of our program today, where you don't have to just me talk. Looking at these, I'm reminded again of how bad my handwriting is in comparison to other people's. But the first one comes from somebody who signed the name of the blue line, and it's recognizing that we can't just scrap the current system entirely. What advice do you give those of us just beginning careers in healthcare policy?
One of the things that I hate to make reference to my conversation with Dr. Gawande again, but one of the things, and I spoke to a group of actually plastic surgeons who do both cosmetic work and other kinds of surgeries that need to be done. As a cancer patient, I've certainly had my experience with plastic surgeons. I realize that they don't get asked much. We're not involving the participants that much in the discussion. And I mean, so one of the crises we have right now in healthcare is we don't have enough nurses. Nurses provide 98% of the primary care in this country. We don't have enough nurses. But you can't just say, well, let's give more scholarships to nurses, because we don't have enough nursing educators. We don't have enough educators to educate the people, the number of people we need. So you need to actually get in and have these conversations with the people who are on the ground. It's great to stand back and have these theories. One of the good things about my particular experience, I came to this by talking to people who were facing these issues. But honestly, sometimes it was harder. I did talk to a lot of nurses, I have to say, over the time, but less to doctors. And it's really important, or to hospital administrators, and finding out what their perspectives are and what their needs are, because too often we're leaving them out of the equation.
The next question, I think, is a really good one. Do you think that the next president should build the reform plan themselves, in much the way Bill Clinton did and Hillary Clinton did in 1994, or should they turn more of it over to Congress and let it be a more congressionally focused process?
This is tough because I'm not that fond of Senator Obama's plan, so I'm a little hesitant to say that I want the president to do it. I'm really not fond of Senator McCain's plan, but I do think that we have so many different voices right now that want to be heard. Right, we have, I think we all think that we're on the verge of an Obama presidency. Certainly 8 days out, it looks like that. But we have a lot of different perspectives on what needs to be done with health care. You look at the different bills that are in Congress now, or in the works right now, they're going to have very different perspectives, and we're going to need some real leadership on that, and there are some sort of titans with respect to health care in Congress. Senator Kennedy is certainly one of those, and you could defer to some of those, but if you end up sort of with the back and forth of that process, I think you'd end up with a lot of compromises. The idea that we can get to do this more than once, we'll do this and then we'll fix this other part later, I don't think that's possible. I think we need to go ahead, and even if it's stepped process, we need to look at the whole evolution that we want to, of reform that we want to accomplish, and do that at one time. So it's going to take, it probably will take leadership from the White House in order to accomplish that.
Mm-hmm. This next one is interesting. I want to add a bit of context to it first, that in this country we pay doctors much more than anybody else does. And we've, over the past couple of decades, seen a real weighting towards specialists and much lower towards primary care. My understanding is dermatology now has the highest MCAT scores in the nation because pays well, choose your own hours, indoor work, no heavy lifting.
Grey's Anatomy, they get massages at work.
Right, see? So this question reads, as a medical student, I'm troubled by the number of physicians who are being forced into declining new Medicare patients or not accepting insurance. With students graduating now with an average debt load well over 100,000, I think 130,000, how can we enable new physicians to go into primary care and/or to serve in-need populations?
It's a really good question, and one of the rationale for these high salaries is exactly that the education they've gotten is so much more expensive than it is in other places. So so they come in with a lot of loans. Come into practice with a lot of loans that need repayment, and that's happening not just in medicine, but nonprofit sectors all over the country are struggling for the best students because a lot of those people are coming out with debts that nonprofit salaries simply cannot repay. So I think there's two ways of addressing this. Frankly, I'd like to see us, instead of trying to paint the pig purple after we've already given birth to it, why don't we figure out a way not to have the pig in the first place? So let's figure out a way to make the education less expensive. So we're not having to figure out how it is we solve the problem of repayment. On the other hand, one of the solutions that you often hear, and I espoused as well on the campaign trail, is that you do loan repayment in exchange for people serving underserved populations, and that's fine. Except that what they get is a series of new doctors who then get their debt repayment and move into more lucrative practices, and you don't have the continuity of care that you really would like to see. I mean, how would you feel? I mean, people in this room are probably not in the category of people who would be in that situation, relying on somebody who was having their loan repaid for their medical attention. But don't you want your doctor now to be your doctor in 7 years and your doctor in 15 years, so that you'll be able to see they'll be able to see the development of your health history in a very personal way. So there's some shortcomings to that, which is why I'd rather focus on how it is we gave birth to the problem, which is in part which is the high costs associated with going to medical school.
The next question is interesting too, I think, particularly given our earlier talk about how quickly can you move away from employer-based system, and I think that gets at the sort of status quo bias of the electorate a little bit, that healthcare is very personal. Right. And you can ask people to change a lot of things, but changing that quickly, change there is something that leaves people fairly afraid. So this asks, how can I convince my parents who are not young but are currently healthy that a fair and equal universal health insurance system is not only in America's best interest, but in their personal best interest? And I just say that I'd add to that because I end up getting some reports from people who are doing calling for the various campaigns on this and hearing this, and people tend to think that when you say universal health care, you mean I'm going to make yours worse and make poor people's health care better. And that's been a sort of long time bugaboo here. So what do you think could?
I mean, I think that if you tell people, for example, that that $900 of their health care costs go to cover health insured today, that's what it is today. And if you tell them that 1 in 6 people, and if you lose your job, or if health insurance if you're paying for your own and health insurance continues to skyrocket, you may be in those uninsured ranks. 1 in 6 of us are uninsured today. And so you look around this room and imagine how many of you would be. And so who does the insurance company? Somebody's raised their hand in the back. And there's so how do we decide who those people are going to be? Well, they're going to be people who are self-employed. They're going to be people who have a pre-existing condition. They're going to be people who have a disabled child in their family. You may not want to choose that person, but the insurance companies choose that person today. That could be their neighbor. That could be their brother-in-law. It doesn't have to be somebody who is panhandling on the corner. These are people who are doing all the things they need to be doing, but they're finding that they're unable to pay insurance. One of the reasons that I sometimes when I'm campaigning, I talk about this woman came up to me and she said, "I'm really afraid for my children." She's working because I don't have health insurance, but I have a lump in my breast. And I thought, what is this? This woman, she has gotten to the point that what she's doing is going to events and trying to whisper in somebody's ear. Can you possibly fix this for me? Because I can't fix it for myself. And what put her in those circumstances was not that she was somehow unlike this fellow's parents. He was just like that fellow's parents. She just couldn't afford health insurance. And that can happen to every single one of us. And the fact that we might feel that we're somehow protected because our health has been good until October of 2004, the only time I ever went to the hospital was to have babies. I was perfectly healthy. You have no idea. So what's coming down the pike at you. But we know health insurance companies pick the family with a disabled child. They know they pick the person with the pre-existing condition. Unless you're willing to say that's okay with you, then you need to make certain everybody has coverage and that those people are not left out.
The next question builds on that well, I think, which is, do you think this country can ever get to a place where healthcare is a basic human right available to all rather than just a luxury? And I'd add to it that there seem to be in the various plans 3 ways of viewing healthcare. Or actually 2, and then there's the question of it being a right. It's a commodity we want people to be able to afford, which is sort of the vision put forward in Obama's plan, that people should buy it, they should have the choice to buy it, but we should try to make it cheap. Then there's the idea that it is a responsibility, that we will try to make it cheap, but we're going to sort of put it on the individual. And there's a question of it being a right. And I thought it interesting in the debate that the moderator asked Obama, and McCain for that matter, if it should be a right, and McCain said no. But Obama... but Obama went up and said, yes, it should be a right, which is interesting because his plan doesn't make it so. Right. So what do you think about that? It's life, liberty, the pursuit of happiness, none of which are possible without good health care. So if that's what we're about, I think it's a moral obligation. We know what's happening. There's nobody in this room that doesn't know how it's working and who it is that's getting screwed in this process. We know who it is, and yet we sit around and talk about it in some abstract way, like it's a commodity, or like, if we just get it to the price point, then people will be able to make the choice whether to do it or not. There are consequences, not just the $900 I was talking about. There are real consequences in the classrooms of our children. There's real consequences if you have a child who's either sick or whose parents are sick, and the disruptive nature of that associated with those things. The constancy of our care of all of us makes all of us healthier, not just the ones who are getting the initial treatment. The other thing that I want to say is that another way to describe this, both of these candidates talk about a medical record keeping, doing those kinds of things that were going to allow us to save a whole lot of money, and I think it will save a whole lot of money. It's going to take a big investment that nobody's talking about. Nobody's putting a number on. I think probably $50 billion would be a very conservative estimate of what it would cost. But to make certain that every provider across the country has access to a way to input information about the people that they're treating into databases, so that a computer, and the CDC can be involved as well, into a computer, so we'll find out exactly what it is we're facing. And that becomes a homeland security issue too. If we were to have a smallpox outbreak, and it would happen in particular locations, but people go to different doctors, how is it we're going to know about that? Because are they going to identify that these symptoms are occurring at a level that create where we really have a risk, or they're going to be misdiagnosed? It's only when the clusters exist. And often we find about the clusters years later. But if we were putting medical record keeping, we all become safer because those kinds of outbreaks are identified immediately because they're all being input into a central database. So even if you weren't talking about how much easier it is, or if you got flooded out like New Orleans, you didn't have to worry that ask me what my dosage is on the chemotherapy I get. I couldn't begin to tell you.
And if that got flooded out, somebody has to start from scratch. But if it were entered into a database, then any kind of interruption like that would also be protected. So I don't know how I got from the right question, but yeah, no, I believe that it's a right, and I believe that not just that it's a moral imperative. It's immoral for us to know that the system is working to people's disadvantage, good people's disadvantage, and we do nothing.
Your husband always had a line that I thought really struck me. He said he would talk about, and I'm sorry I can't remember the man's name anymore, who wasn't able to get hair lip surgery. And he'd always say, this man couldn't speak until he was 50 in America.
Right. James Lowe is a man, and I was maybe mad sometimes when John would tell the story because he would never say this. James Lowe's father worked in the mills, worked in the mines, and James Lowe worked in the mines too. It wasn't that he didn't work; he didn't sit around. He actually worked, but he was born with a cleft palate. It cost $3,000 to fix it. They didn't have $3,000, and their employer did not provide health insurance, so he didn't get it fixed until one of these medical groups that goes into rural areas came one time, and finally James's number was up, and James got his cleft palate fixed. His cleft palate was so severe he couldn't speak. Not only, but he got it fixed, and now he can speak at 50. So 50 years he couldn't speak, during which time he married, he had children, he lost a child. Having lost a child myself, I think, you mean he lost a child and couldn't speak about it? I mean, it's just this. In this country, this is a working person. This is not somebody who's not doing what he's supposed to be doing, but he's doing what he's supposed to be doing, and this is what happens. In a country of this, where we spend how many, I'm guessing that we spent more on mascara during the time we've spoken here tonight in this country than that operation cost. I think that's a pretty easy guess. More on mascara in this country, and yet he doesn't have that operation. How can we say it's not an immoral test that we're failing?
And no health insurance working in a mine. It's incredible. I'm going to read these two questions together because I actually think the questions themselves make a point. The first one reads, I'm a young, healthy 20-year-old female. I recently learned that I inherited the BRCA1 genetic mutation that increases my odds of developing early onset breast cancer and ovarian cancer. How do McCain and Obama's health plans affect someone like me? And more importantly, would either plan help spread access to this exorbitantly expensive but crucial test? The second one reads, as a 31-year-old breast cancer survivor whose symptoms were ignored due to a combination of young age and lack of health insurance, what can be done to combat the myth that young people don't require comprehensive access to health care? And I'd add to that to diagnostics.
Yeah, now young people on breast cancer, I think there's growing attention to the fact that young people can get breast cancer, and they're particularly in African American communities a really aggressive kind of breast cancer that is really prevalent in younger women, and that's being identified, and so there's intervention where there's health care. Of course, the problem is where there's health care. I think that we're getting a little more attention that. But the problem, of course, is that we're not encouraging mammograms at an early enough age. Certainly at least a baseline, and then periodic testing. For the person with BRCA, with the genetic predisposition, fortunately, GINA, which has to do with your genetic predispositions to particular conditions, I believe that was passed last year and signed. And what that means is that insurance companies cannot discriminate against you based on that. I'm right about this, right?
Yeah.
Thank you. And so that means you can't be discriminated against in terms of your. But the question, of course, is whether or not they're going to find that the kind of diagnostic tests you're going to need to be medically necessary at the earliest possible times. And that's still another standard that I don't know. I frankly don't know whether you're going to be able to have. But I'm hoping this is part of the reason why the research money is so important, to identify these conditions and when it is we need to be testing for them at the earliest possible, so we can intervene at the earliest possible time.
Right. And that bill was interesting, just to go back to something else you said, because one of the big problems in the system is you don't get coverage for pre-existing conditions. So if you've had breast cancer, you cannot get health insurance. If you've had a test showing that you are one day going to get breast cancer, they can't deny it to you. morally, there's no difference. One person didn't do a worse thing than the other. They didn't smoke all their life necessarily. None of that. But because we had to face that one directly, because if we didn't do something about genetic testing, it could break the system, we did the moral thing. Because we can let the other thing happen implicitly,
right.
And most of us can get it through the employers, we can let that one sort of fester.
Yeah, I have to say, what was happening, too, was, I mean, my daughter, there was an incentive prior to that. I got breast cancer in 2004. An incentive for my daughter, who at the time was 23, not to get tested. She could get I could be tested, she could be tested to see. There was an incentive for her not to be tested so she wouldn't be identified in her medical records as having this condition. So obviously, you know, the laws were actually working to discourage people from finding out what kind of interventions or screenings and things they were going to need to have.
So the next question is, I think, a useful one to have. If there is to be socialized health care.
I don't see.
Y'all ready?
We don't see John McCain in the audience.
He's very short. He's actually in the back. How do we as a nation deal with people who make intentional lifestyle decisions that harm their health and thus our total spending, like smoking or eating too many fatty foods? It doesn't seem fair to those who don't make those decisions.
This is an argument you hear all the time. I went to high school, my senior year of high school in Alexandria, and I used to read the Washington Post. And one of the stories in the Washington Post when I was a senior in high school was a story about a couple who had decided that food stamps were more than ample. And you could get a well-balanced meal. You did not have to eat fatty foods. You get a well-balanced meal with the food stamps that were available at the time. And what they did was they took the amount of money from the food stamps, and they ate that for a month or something. They clipped coupons from the Washington Post and other newspapers, the Thursday paper, I guess, is the paper with the coupons in it, and got Women's Day and Family Circle and clipped the coupons there, and then they find out where the specials were in the places, and they go around to the different stores and buy the specials. If you're poor, are you going to be doing that? And I want to ask you another question. Have you ever been inside? Go to a rural community, which doesn't, that might have a little Winn-Dixie or something, or even worse, that has just a small, that really has just a small market to serve people in it. They're not going to have fresh fruit because they can't. It costs them too much to get it in. It goes bad and they lose money. It is much better if they stock things that are not as perishable. So they're going to have exactly the kinds of things that the people who shop there shouldn't be eating. And then we say that voluntary action by that person put them in a position where they cause their own diabetes. If we start making decisions about what is a voluntary action and what's an involuntary action, I think we're going to put ourselves in a very bad place. Oregon tried several years ago to do, and I thought it was a valiant effort. They tried to ration the particular kinds of care that were going to be covered under government insurance programs. And if the cheap kinds of treatments, they'd all be paid for. And as it got more expensive, they made decisions about whether this was, I don't think they made any on whether it was voluntary or not, but whether it was going to be productive or how much lifespan you had or other kinds of things that might affect whether or not they should be investing in that person, whether they were a person who was worthy of investment. Do we really want to be there? I mean, I think that was part of the problem with is that you understood and even applauded the ingenuity of the effort. But do we really want to, as a nation, to be in a place where we're making these decisions? One of the things you're talking about smoking. One of the things in smoking, the lawsuits with respect to smoking are the targeting of young people when they're not at an age where they make these decisions, and they become and the way in which they are insidiously creating dependencies, and the tobacco companies. And so you've got a situation where, is that really a voluntary act? I mean, at what point? And I just don't think we ought to be making those decisions. Certainly there's going to be really egregious examples, but I'd rather take care of the one who's the egregious example than to start making decisions about everybody. I mean, that's my personal perspective on that.
Mm-hmm. What about, I think we got time for 2 more, is that about right? Okay. So somewhat related to that, what about the problem of misuse and overuse of healthcare, especially therapies that have not been proven? People hear that something will work, or more than that, you hear on the other side of things, defensive medicine, doctors prescribe things that aren't of huge clinical value, but will make them safer. The patients actually want them. You hear about lumbar surgeries, which don't do much, but if people have tried everything else, they then try that. That on some level, we have to be able to make decisions, but for everybody in the system, for doctors, the incentive is always to more care. That patients want more care. They want to be able to help. They make money for more care. For patients, too, very often the incentive is towards more care. Things haven't worked now, but maybe it'll be one of the few for whom that other thing does work for.
Right. Well, in terms of, it's one of the things that insurance companies have often done is to deny people who are in clinical trials coverage. I was in a clinical study at Georgetown when I was getting my treatment here, and I had to sign a form that said, you understand your insurance company may not pay for the additional MRIs that you'll be getting as part of this study, and you may have to pay for them. It doesn't exactly encourage people to participate in those studies. So some of the stuff that's going on, we want to it's like we want to get people to get the genetic testing, so we need to make certain that the system works to allow them to do that. The same thing is true with some of these seemingly untested therapies. We want to find out whether they're successful. We want to be able to solve people's problems efficiently. My experience with in the military is that we didn't have long lines of people. People, if you had a health problem, you would go see about it. And if you continued to have it, you'd continue to go see about it. But people weren't getting unnecessary treatments. It's like you said, you're not, this Saturday or Sunday, you're not thinking, if I could just go get some diagnostic test today. You do it. I mean, if people have real problems, they go. And is it possible that the first year you've got a flood of people who've been holding up all those, it's like the lines of people in those rural areas to get treatment. If you've ever listened to those people, they had a 60-minute special on RAM, the rural area medical group, and people would come in and I have a toothache and I have a lump in my side and I have my knees bothering me. They have a whole list of things they've been saving up. So would you get a little of that first? You probably would. But then as those things got treated, as we hope they all would, I think things will happen in that orderly way that they did at the military hospitals. The same thing is true of the infirmary. I mean, people who might not have had health insurance someplace else can go to the student infirmary in a lot of places. It's not huge lines at the student infirmary. People go and get the treatments that they need. Now, what do you do about defensive medicine? I think that we probably do need to find some way to make certain that people are not ordering tests simply because they don't want to be sued for not giving not ordering the test. So we need maybe some sort of, if the doctor really doesn't think it's necessary, but having told the patient that this test is available, as they should be telling the patient, this test is available. There's a 1 in 1,000 chance that this test is going to tell you anything useful. Do you want it? And if you're really sick, you say, I want to check every box and make certain I don't have it. But somebody maybe needs to be intervening and in a way, and I don't know how to. I have no idea how it is you do this to basically say that this is the treatment. But the one person who can't do it and who would do it under the McCain plan is the insurance company. Shouldn't be making that decision about whether or not the test is covered. But the doctor, the patient, and maybe some sort of board when the doctor thinks this is really unnecessary treatment, but wants to protect themselves.
So, and here is the final question, which I think is a hard one. These other ones you seem to just sort of bat them away. So we got one here that some of the main opponents to a socialized, healthcare system say that it would thwart innovation.
Use a different pen too. It's very clever.
Right, no, it's very clever. This one, as you may imagine, is red though. So, some of the main opponents to a socialized healthcare system say a socialized system would thwart innovation. Competition is good. And a sort of corollary to that is you then say, oh, well, in France they have all the technology you'd want, but then the people say, well, we're just subsidizing the French. If we stop doing that, drug producers will stop making important drugs and we won't have as much innovation. So how do you respond? How do you do this in such a way that there remains an incentive for innovation?
I think it's a legitimate question, and this is the same pen that he's been using on the map at home. He has, and he's been writing it all in red. A legitimate question. One of the reasons that you actually the hybrid system where you had from the insurer's perspective, where you had Blue Cross participating and also a Medicare Plus government kind of program participating, is that government's very good at efficiencies, but not very good at innovation. And the innovation has come from the private sector, and so you do want to keep, as part of the process, you want to keep that tension somehow in there. That's one of the reasons why I think that the weaning off of that would, the longer it takes, we're not necessarily any worse for that. And there's still, we are a country based on capitalism. There needs to be a profit margin available to people. It doesn't need to be the obscene profit margins that we have seen. If Merck, who's I think actually a pretty good company, and it's just the only one I could think of off the top of my head. But if Merck wants to make a good profit, I think that's fine. If they want to make the profit entirely off the U.S. consumer and and basically have us subsidize drugs around the country, around the world, that's really not something we should be have a system that not only permits but encourages. And so we need to find ways that that their profit is not at the expense of the American consumer. I think there's always going to be a room for the next machine, for the next therapy. The people who went to school for that long, they want to put that to good use. They want to have the people who went into medicine, who go into medicine, blow me away, honestly. That they want to find answers, and so I don't think we're going to see an end to innovation. And I think that the extent to which we want to continue to pay doctors at a level that rewards them, as opposed to, example, the doctors in Japan, where they spend very little of their GDP. We spend 17% of our GDP on healthcare. They spend less than 8%, I think, on their healthcare. But doctors are paid, like teachers are paid here. We want to figure out a way to make certain that their work is rewarded, so they see a personal incentive to continue, as opposed to just to get these patients in and out of their office, because they're not going to really benefit from it. I haven't got a great answer for this question, except I don't think that whether it's socialized or not has much to do with it. I think that what has to do with is whether or not there's sufficient profit in the it can be socialized in terms of being available to everybody, but as long as the people who are, the wages are sufficient, or the people selling the machines are recompensed adequately, or the pharmaceutical companies are getting enough money. That's where the innovation is occurring, not in the actual delivery system between your insurer and you. That's not where the innovation's honestly occurring, except, as I said, some of the savings that we've seen coming out of private insurers' innovations. Now, I wish I'd had a stronger answer. You're right. You just beat me. Why go back to one of these easier ones back here?
I think your answer is fine, and I think everybody appreciates you being here, and I think we thank Campus Progress and the George Washington School of Public Health for having us tonight, and for all of you for coming out in the rain. So.